Welcome everybody. My name is Enrique Arellano. I'm in Barcelona, Spain. I'm the director of the Four Cycles Institute in Barcelona for psychotherapy. We promote neuroaffective models of psychotherapy, and we are so proud to interview today Dr. Frank Corrigan, who's been a psychiatrist for adults in the National Health Service in Scotland for over 30 years. And he's combined his extensive clinical experience with research of neurobiology of trauma and its underpinnings in major psychiatric disorders. His research broadly explored the intersection between effective neuroscience and the science of healing, culminating in the recent 5 past years development of deep brain reorienting. This is a new and novel psychotherapeutic approach that emphasizes the importance of tracking distinctive neurophysiological sequence embedded in deep brain systems. One of the most unique aspects of DBR as a trauma-focused therapy is the embodiment of a natural healing process that is consonant with the evolutionary process of the developing brain and the nervous system. I also want to mention that Dr. Corrigan is an award recipient from the International Society for Trauma and Dissociation, and the award was given to him. It's called Cornelia B. Wilbur Award from ISSTD International. So thank you for giving us this time, Dr. Corrigan. And I would really like to hear from you more about your development with DBR. How would you introduce DBR for novel clinicians who have never approached this methodology, this, how would you say, it's a method or a model of trauma treatment? What would you say about DBR?
Yeah, well, first of all, Enrique, thank you for inviting me to be here. It's a pleasure to be here and talking to your group. I know that you're going to translate into Spanish what I say, so it's nice to be able to reach parts of South America as well as Spain. And a lot of the good work in trauma, I think, has come from South America, if perhaps from the Portuguese-speaking areas of Brazil, but a lot of the trauma studies that I've relied on over the years have come from Brazil, others from Australia particularly, and other places. And so to give you a little background about deep brain reorienting for the sake of therapists new to it, my aim has been to try to make trauma therapy as safe and effective as possible. And as a general psychiatrist, I could see many post-traumatic conditions that were causing serious risk of self-harm and suicide, but it was difficult to apply standard trauma therapies to these conditions without overwhelm, without the patients becoming overwhelmed, more distressed, more dysregulated. So I've been interested in how trauma therapies work and trying to track what's happening in the brain during effective trauma therapy. And it's led to this way of working called deep brain reorienting. For therapists who are new to it, I would say that the first thing is that we pick a moment that grabs the attention in the traumatic experience or event. We're looking to get a moment in which the body reacts, because often the brainstem and body reactions come before the emotional and the cognitive reactions. So we're looking to get into that first moment when the body reacts to something going wrong, something bad being about to happen. And what we've found is that in that moment, that first moment, when the brainstem and body react, there's often a moment of shock through the body. So there's a sudden charge of energy through the body. Perhaps the muscles brace, the head goes back, feeling of hollowing or emptying or shivering inside, a cold surge down the spine. To something on those lines would represent the initial shock response of the brainstem and the body. And then just after the shock, we would usually get the affective and the defensive responses. So we would get the fear and the flight response, or the rage and the fight response, or sadness or shame and tendencies to withdrawal. And emotions are so preoccupying of our attention that the shock gets left behind. We don't notice the shock energy. What we're aware of then is the fear or the rage or the grief or the shame and the thoughts that go with those. I'm going to die, or I've suffered such a loss, how will I cope? Something in those lines then takes over the awareness. So when we start DBR, deep brain reorienting, our main aim is to get back to the beginning of that process and slow everything down, taking it really slowly from the moment of the attention grabbing to the moment of the shock, before the fear or rage or grief or shame come in. And what we've found is that if we can isolate the shock at the beginning, the shock in the body, if we can separate it out and allow it to process before the emotions come in, the processing goes much more smoothly for the patient. Because often I think if we have, an experience, and let's say an experience of an assault, an interpersonal assault, the person who's being assaulted, the victim, may at first be shocked by the attack out of the blue. The panic system can then come in with, I'm on my own, there's nobody here for me, and the feeling of aloneness can be intense. Then can be the terror, I'm going to die. And if we have all three together, shock plus panic plus terror, and we bring them all up at once in therapy, we can get overwhelmed. We can just be overwhelmed by the combination of these. So if we can slow it down and say, we'll get to the panic in a moment, let's process the shock first, then the shock energy diminishes, then we take the panic and we breathe through that, and then we take the terror. If we're able to slow it down and take these in the sequence in which they originally occurred, that allows for a healing process to come from within the person who suffered the trauma. And that healing process then follows its own course in the way that the person needs, and there's a release of the distress and a relief from the distress and from the body sensations that go with them. So that's the kind of thing that I would explain to new therapists, that we're looking to get these sequences related to the trauma and allow them to process.
Yes, so in DBR training, new practitioners new to DBR learn from you all the neuroscience that sustains the shock, the panic, the terror, right?
Yeah,
How does the brain, which structures of the brain are involved? When are these triggered? Is that correct?
that's correct. That's what we do, is we teach the neuroanatomy, because we see that as fundamental to the healing process that we're promoting here. And one of the key things in DBR, and it can sound a small thing to people new to DBR, but one of the key things is that before there's even a shock comes into the body, there's an orienting tension. And when we are grabbed, when our attention is grabbed by something threatening, the first response in the body, even before the shock, is an orienting tension in the forehead and the muscles around the eyes or at the base of the skull. And we look to identify that at the beginning of the sequence. And we find that if we can identify the orienting tension, that not only opens the file for processing of the traumatic experience, but it also acts as an anchor. It acts as a grounding mechanism for the processing. So the patient or client is much less likely to become overwhelmed if you identify the orienting tension right at the beginning of the sequence, before the shock and before the affect.
Thank you so much for this. It really makes a lot of sense to me. And I'm thinking of people who are maybe in their consultation room and are not expecting any of these reactions from their clients. They just speak maybe a narrative, they maybe just expect a narrative or a shock or a picture. And you want to say something about this?
Yeah, happy to. It's taking the processing immediately to a different level of the brain, because a lot of the time in traditional psychotherapy and traditional talking therapy, we're talking and listening, and we're hearing a narrative, we're hearing about episodes that have happened. And in deep brain reorienting, we're getting to a level below the narrative. We're getting below the chain of events that happened into the chain of responses in the body to the key moments of that narrative. So DBR can sometimes be a very quiet therapy. We can set up the sequence at the beginning. We identify our orienting tension. We process through the shock energy. We sit with the affects that are coming through. And the person's process coming from the deep level can often be in silence. And we just sit with the person who's processing, watching attentively and waiting until they say, "Oh, that feels better now. Something is cleared."
Yeah, so this brings back to the therapist an opportunity to be holding their client in their presence, in their awareness, in their mind and heart, as they track the process that they are just holding because they don't know really what's going on inside, right?
That's right. They're holding the space for the client and for the client's healing, holding the space between the two people so that the space is safe and grounded and present and allows that natural healing to flow.
Exactly. So, because I believe DBR, you did a study with DBR, and the study delivered some results that are remarkable. Would you like to comment on this a bit?
Well, I've been very grateful to have the support of Professor Ruth Lanius at the Western University in Ontario. And Ruth Lanius and her team organised a randomised controlled trial of 8 sessions of deep brain reorienting, 8 sessions that were online because it was during the pandemic. So all of the sessions were given online or by telephone. But what they found was that the ratings were done by a rater who didn't know whether the person was on the waiting list or in the active treatment group. So the raters were blind to the condition of the treatment. But what they found was that when there was very little change in the waiting list group over the time of the assessments, but the people in the DBR group showed a significant benefit in terms of their PTSD scores after just 8 sessions. And curiously, the effect size continued to increase 3 months after the 8 sessions. So it wasn't just during the time of the therapy itself, but the improvement appeared to continue to deepen in the 3 months after the ending of the 8 sessions. So that was a very nice support for the clinical use of deep brain reorienting.
Yes, and the sample group of participants were people with any kind of trauma or something specific?
No, it was any kind of PTSD, so there was no exclusion of people with dissociative disorders, for example. So the active group was 23, the waiting list group was 23. So they're continuing the study in the hope of increasing the numbers over time. And also we should have brain imaging results from before and after the DBR sessions. So that's a very exciting possibility, but we haven't got the numbers high enough yet because of the pandemic. Some people couldn't get scanned, so
Yeah.
we're just building the numbers up.
That's amazing. Wow.
Yeah.
Thank you. And just changing a bit of topic, in the areas of intervention, you mentioned shock trauma, like an assault, but you have also mentioned somewhere attachment trauma. How do you see that DBR is helping clients who have attachment trauma? How does this is supported by DBR?
Yeah. Initially, one of the aims, or one of the things that led to the development of DBR was a wish to treat an attachment shock from a recent event, and it wasn't related to, it wasn't obviously related to an early life event or to a young part of self. It seemed to be a shock in the recent past that came from an attachment wounding. So we developed the application of DBR through applying it to the stimulus of the rejection, the painful rejection. We picked up the shock, then we picked up the affective responses to it. And the change was pretty dramatic, quite quickly. So that meant for me that DBR could be used for recent events, but it also could be used when the trauma was primarily interpersonal or relational rather than, an earthquake or a shooting or a bombing or car accident or something of that sort. And what we've found is that if we use activating stimuli from difficulties that arise in present relationships, we often seem to be picking up sequences in the brainstem that go way back to infancy. So, for example, if a person says they always have a strong reaction to their partner not replying to them, perhaps the partner is so involved in watching the TV that doesn't notice the person speaking, and they feel this sense of rejection. They're saying something, all they get is a still face and no words. That response can often include shock, and it can include an attachment conflict, which we often think goes back to early life. So the infant who, for example, is about to reach out to mother and then sees she's not there, or she's angry, or she's terrified, is going to be held briefly in that conflict, whether to reach out or pull back. And that moment of conflict can include a shock through the body prior to the affective responses. So we find that we're able to get into attachment conflicts from very early life, often by looking at what's happening in the person's relationships in the present and looking at those moments that they find painful and they don't know why they're so painful, but they just know that they react, for example, with extreme rage when it doesn't seem to really be a particularly severe rejection.
Exactly. Thank you. This makes so much sense. It's like the internal working models are working still from
Indeed.
the past. Yes, yes.
Indeed.
So
Yeah.
this is where these tensions and emotions are first released. And it seems like a key component of DBR is the observation of the sequencing of how all it unfolds from the brain perspective, right?
Yeah, because internal working models have not been defined in brain terms. Most of the people who look at attachment look at the prefrontal cortex and the capacity for attunement and so on. We're looking at the brainstem and these basic tendencies to reach out or to pull back, to turn towards or to turn away from. These are all happening in the midbrain.
Oh, yes.
Yeah.
There are milliseconds, splits of millisecond, and require a high level of personal awareness to even track that we're doing those things.
Yeah.
As human beings, I mean, not as clinicians as well, we need to be able to track those milliseconds of response, reaction, right? Head turns.
Yeah. Yeah, they're so fast, and if we're not looking for them, we won't see them.
Exactly, exactly.
Yeah.
That's so great. And I love that you just shared this, because I think many of our participants will be very willing to engage with DBR. And I wanted to ask, there are so many trauma processing models nowadays, and I'm conscious of some of them that work with eye movements or stimulation or brain hemispheres or some body sensations and pendulum or chronic movements intended to release. How would DBR fit into this larger family of trauma processing models without demeaning any of them, but see
Yeah,
what
yeah,
would that be the way to understand at which level is DBR working compared
yeah,
to the others, of course.
yeah. And there are many good and effective trauma therapy models available. So I'm never saying that DBR is the only way to work. But I think the strength of it has come from the brain basis of it, from the hypotheses that we are using in terms of what's happening in the brain. And many of the current models use a triune brain model, and they see the brainstem as part of the reptilian complex described by MacLean in the triune brain. That, we think, was a misinterpretation of MacLean, because he actually talked about the neomammalian brain being the neocortex and the brainstem nuclei with which they interacted. He talked about the limbic system being the limbic structures and the brainstem nuclei with which they interacted. He saw the reptilian complex as the basal ganglia-based movement tendencies and so on that came from the other areas. So we're seeing it differently. We're seeing the midbrain as an integrative hub that's taking in information from the cortex, from the limbic system, and it has all of that information available when there's something significant in the environment to react to. So the midbrain can then produce this immediate response of orienting to something salient with the orienting tension, and then with the shock if it's something horrifying, and with the affective and defensive responses. So we think that DBR is working from a different model of the brain, and this focus on the upper brainstem structures is giving us an effective way to work with the most immediate responses of the brain and body.
Great, great. This is very plausible. Thank you very much. So, sorry. So, in order for people to learn what to expect from the training, there's level 1, there's level 2, there's level 3, and then there's consultation practice.
It's good if people can do the 3 levels. The level 1 is the basic training, where we cover the neuroanatomy of the basic shock and affective responses. The level 2 is more focused on attachment and how we get back into these early responses and what responses may have led to pain, emotional pain, and how that may have affected a growing individual, an infant or a young child. In the 3rd level, we focus on complex trauma disorders that present more of the model of dissociation and talk about other conditions like obsessive compulsive disorder and so on too. And then when people have done all 3 levels, it's certainly useful if they can be in a consultation group, and continue to refine their clinical knowledge and skill over time. I have found that even when people have done all the 3 levels, when they're coming to consultation groups, they're still learning, because the material is very deep and detailed, and it's useful to keep going over it and to keep going over how it applies in clinical situations.
Great. That's great. Thank you so much. And we look forward to hosting DVR for the Spanish-speaking community and bilingual communities, as it will be delivered in English, but we will provide Spanish translation by our clinically informed translators. And and that's upcoming. So anybody who's curious and would like to see what the program is like, you can come to our website. And or it's all from my side. And is something would you like to comment before we close this interview?
No, I think that's been a great opportunity to cover the basics of deep brain reorienting. So once again, thank you for inviting me.
It's such a deep honor for me to have this opportunity, and thank you. And well, I'm just looking forward for all these people who are willing to upgrade their clinical skills by integrating DVR into their working toolbox and see the power and the depth it can come by releasing shock and pain and panic and terror on a deep level, and see how that helps them and their clients move swiftly through therapy and restore the wellness again.
Thank you, Enrique.
Thank you, Frank. Bye-bye, everybody.